So today's class is going to focus on MCCQE1 Objective 5. Objective 5. And Objective 5 is very important because it's entitled Attention, Learning and School Problems. Attention, Learning and School Problems. So welcome again to everybody joining us. When you get into this objective, the Medical Council of Canada wants you to know that school and learning problems are among the most common reasons for children to present to primary care clinicians. And that is one reason why I always say something very important when I'm teaching classes. I always tell candidates that, look, common things are common. Number one, the exam is at the level of a Canadian medical graduate. Number two, the topics there are common for everyone, to be able to deal with. And number two, you also have to understand that difficulties at school can be caused by treatable medical and developmental conditions, which, if unaddressed, can lead to long-term psychosocial dysfunction and chronic health problems. So if I were you, I'll ask myself, if this is what a rationale of the objective is saying, then what are some treatable medical conditions that can lead to learning, attention, and school problems? And number two, what are some developmental conditions that can lead to attention, learning, and school problems? And you realize that if you focus on what the Medical Council of Canada says, you want to pause and reflect on something. So I have a question. With this, what are some treatable medical conditions that can lead to children having issues with attention, learning, and school performance? And what are some developmental conditions which cause children to have attention, learning, and school problems? Can somebody help me? Or maybe you can type it in the comment section. What are some treatable conditions? I'm checking on the Facebook guys as well. So if anyone has any contribution, I can also see what they are saying. So what are some of them? Please, you can type your answers and I'll go in and check for you. What are some of them? So autism, beautiful. ADHD, beautiful. Visual problems and hearing defects, beautiful. Autism, autism, autism. So you see, all of a sudden, you are even learning the topics you need to know for the exam. People are talking about autism. People are talking about visual impairment, hearing impairment. So when you are learning, you just have to know, okay, why are people able to tell which topics they have to learn for the exam? It's very simple, because if you go through the objective, you will know. So I always say that think through treatable medical conditions that can cause problems for children. Think through developmental conditions that can cause trouble for children in school and write them down. So I saw that some people wrote. So number one, ADHD. Number two, specific learning disorder. Number three, autism spectrum disorder. All right. So if I were you, whichever textbook I'm using or whichever reference I'm using, after I list all these things down, then I'm going to go and list my topics and rather use my topics as learning tools. Sensory impairment can also lead to attention, learning, and school problems. And those sensory impairments can be hearing and visual impairment. And then children with seizure disorders as well. And fetal alcohol syndrome. And children with mental disorders, so like anxiety, depression, psychosocial stresses. So like hunger, a child who is always hungry, a child who is from a low socioeconomic status. Adverse childhood experience like abuse, all those things. And then children with obstructive sleep apnea, as well as, because of the prevalence of drugs of abuse, you can have children who are exposed to substance abuse and children who are, children who have addictive concerns. So please, if I were you, this is what I would do. So because of that, I've rather taken my time to list those topics. So under this objective, you have about 12 topics you need to review. ADHD, we'll review that in class today. Specific learning disorders, we'll review that in class today. Autism spectrum disorder, we'll review that in class today. Fetal alcohol spectrum disorder, we'll review that in class today. And then I'll leave the rest for you. Hearing impairment, we usually cover that under ENT. Vision impairment, we cover that under ophthalmology. Seizure disorder, we cover that under neurology. Mental health disorders which cause children to have attention and learning problems, we cover that under psychiatry. A hungry child, we cover that under abuse and psychosocial issues. So we've addressed all this in our lectures, but because we are having a live lecture, I want us to pick 4 conditions and deal with them. Obstructive sleep apnea, we also deal with it in pediatrics and respirology. And then substance abuse related and addictive disorders, that's also under psychiatry. But today I want us to pick these 4: ADHD, specific learning disorder, autism spectrum disorder, fetal alcohol syndrome, and then get to it. Please, are you all okay with that? You can use the objective to predict what you have to know for the exam. So 1 objective, 12 topics. Can you imagine? 1 objective, 12 topics. So step 1 is that you have to list and interpret critical clinical findings, including those derived from a thorough medical and developmental history with a focus on potential causal conditions, okay? An educational history from school staff and a physical exam with particular attention to signs of neurologic or genetic causal conditions. So in other words, with all these topics we've listed, the 12 topics we've listed, you have to know how they will present through history. You have to know how they will present through physical exam and the unique things you'll pick up. So because somebody said ADHD, I want us to start with that. So I've gotten a small video of a child, he's in school, look at the table, messed up. The child cannot, sit upright, turning, and this child is seen as distractible by everybody in the class, by the teacher. So let's start with ADHD. So I have a first question. This is CDM. You are evaluating a 6-year-old child. You suspect ADHD. List 2 features to look out for. This is a CDM question I am giving you. You are evaluating a 6-year-old child. Remember, we are dealing with attention, learning, and school problems. You are evaluating a 6-year-old child. You suspect ADHD. List 2 features to look out for. Let's go. So I've seen some answers. Dr. Lucci is hyperactivity. Dr. Aruj said distractibility, irritability, less concentration span. Dr. Simran said inattentiveness and hyperactivity. Dr. Faizan Khan said distracted. Other people are saying distractibility, inattention and hyperactivity, impulsivity. Beautiful. Okay. So what does the textbook say? Persistent and pervasive inattention. So children with inattention, persistent inattention. Number 2, children who are hyperactive. Number 3, persistent impulsivity. These are the features of ADHD that you need to know offhand. You need to know this like crazy. Inattention, hyperactivity, impulsivity. Inattention, hyperactivity, impulsivity. At the end of the class, I will ask 4 doctors to do a quick oral review for me. So please take notes of the points we are making. Pervasive inattention, hyperactivity, and impulsivity. Okay. Now, that same case, you are evaluating a 6-year-old child. You suspect ADHD. What is the appropriate age to start screening? A, more than or equal to 1 year. B, more than or equal to 7 years. C, more than or equal to 5 years. D, more than or equal to 4 years. What's the right answer? Dr. Tasmin said B, more than or equal to 7 years. Dr. Ahmed said C, more than or equal to 5 years. Dr. Smart said D, more than or equal to 4 years. Dr. Simran said B, more than or equal to 4 years. And then Dr. iPhone is saying D. People are going for D. Dr. Noon went for C. Dr. Noor Torani went for C. Dr. Joanne is going for C as well. I will tell you that the answer is D. Textbook and like official pediatric portals say that when are you going to screen a child for ADHD? Children more than or equal to 4 years of age who have symptoms of inattention, hyperactivity, or impulsivity, or who have complaints frequently associated with ADHD. That is when you screen. So please write this down as we study. Write it down as we study. When am I going to screen a child for ADHD? When that child is more than or equal to 6 years. More than or equal to 6 years. Please, is that okay? We've learned about the features of ADHD. We've learned about the timing of screening. Does somebody have a question before we move on? I want to make sure that we move step by step and we don't leave anyone behind. Step by step, step by step, step by step. Impulsivity, hyperactivity, inattention. When am I going to screen? More than or equal to 4 years. Okay. In which areas of the child's development will ADHD affect? You realize that ADHD will affect the child's school performance. It will also affect their social skills in making and keeping friends. And it will also even affect them when they have to build teams. So in team sports, ADHD will affect all these areas of their lives. ADHD will affect all these areas of their lives. So please, when you're learning, remember to learn the areas of the child's development which the ADHD will affect. And as I said, at the end of the class, I'm going to ask about 4 doctors to do reviews on each of the topics we are doing. So please, if you're interested in ADHD, start paying particular attention to these things. School performance, difficulty making and keeping friends, and difficulty with team sports. Okay, so now, another question. Maybe I'll let somebody read this question for us. Please, can somebody volunteer and read this question for us, please? I don't want to be the only one who is speaking. If you can volunteer and speak, I'll be very glad.
Okay, I will read.
Okay, Dr. Smart, please read for us.
You are evaluating a 6-year-old child. You suspect ADHD. Which other coexisting conditions will you look at for? List 2.
Beautiful. So in other words, the literature says that ADHD at times comes with other coexisting conditions. What other coexisting conditions can you look out for? Dr. Smart, will you want to give the answers?
Tourette syndrome and conduct disorder. Yeah.
Tourette syndrome, conduct disorder. Any other ones anyone wants to add? That's very good. That's very good. OCD, obsessive compulsive disorder, hearing impairment, substance abuse. Well, they can also have anxiety. So apart from Tourette and conduct disorder, and remember, conduct disorder cannot be diagnosed until what age?
18 years.
16, sorry, I think
it's so they have to be older. So this child, instead of conduct disorder, what will you say?
Antisocial.
Is it antisocial or oppositional defiant?
Oh, yeah.
It's oppositional defiance.
Exactly.
Yeah.
So in this child, you rather go with oppositional defiant disorder. If it persists, then you're thinking about conduct disorder. So other conditions which can manifest with ADHD can be, number 1, anxiety, number 2, mood disorders, number 3, learning disorders themselves, and number 4, sleep disorders. So please write these down, write it down. Okay, good. So anxiety can come with ADHD, mood disorders can come with ADHD, learning disorders can come with ADHD, and sleep disorders as well. Let me see, some other people send some oppositional. Dr. Ru said 15. Okay, so now another thing I want us to note, if you get a patient and it looks like the child is just being evaluated in one setting, when I say one setting, I mean maybe they said, oh, the child is having issues only at home, or the child is having issues only at school. You cannot make a diagnosis of ADHD. Why do I say that? The evaluation for ADHD requires information about the child's behavior in more than one setting. In more than one setting. And these settings can be home plus school, or home plus after school program, or school plus after school program. So maybe the child goes to, a sports game, that because we said that they cannot form team-based learning. Okay, so they are having the symptoms at home, they are having the symptoms at school or an after-school program, because you can't just use one setting to make that diagnosis. Please be careful about that. Okay, so we are learning the tidbits about ADHD. We're going to switch from there because we are looking at the historical features. Remember, the objective said that we should focus on historical features. So let's go to learning disorders as well. We'll come back to ADHD, but for now, let's go to learning disorders. So when we say a child has learning disorders, what we mean is that that child has difficulties mastering academic skills. And the academic skills are below those expected for the child's chronologic age. Because remember that in Canada, children are placed in school based on their age. And there's an interference with academic or occupational performance in that particular child. Okay, now, how will the learning disorder manifest? There will be failure to acquire reading skills, failure to acquire writing skills, failure to acquire math skills at the grade and age expected for that child. So if the child is, say, 7 years and is expected to have specific skills, you realize that if a child has learning disorders, they will have things which are below, their activity will be below that. Now, so I want someone to take this case for us, read this case out loud for us, and then let's see how we're going to handle it. Remember, we are still on MCC Objective 5. So will anyone volunteer to read the case for us?
Yeah, okay. You have a troubled mother brings her 7-year-old child to the clinic.
Mm-hmm.
There is a concern about a possible risk factors of learning disorders in the child. What risk factors will you inquire about? List 5.
Beautiful. Dr. Med, thank you very much.
No problem, sir.
What are the risk factors for learning disorders in children?
It could be low socioeconomic. It could be hearing. It could be visual.
Beautiful.
It could be another child that has the similar things in the house. It could be nutritional factors.
Mm-hmm.
Maybe he's not getting
So yeah,
hearing, vision. Yeah.
Beautiful. Visual problems, speech problems, family history of learning disability, hearing. So you see, the exam is nothing wow. As I said, why will a child have learning disorders at home? It could be a family history of learning disorders. It could be something in the family. It could be poverty. And because of that, the child is not getting, resources to cause adequate stimulation of their brain, right? It could be that a child with prematurity. So look at the child factors, look at socioeconomic factors, look at family factors. It could even be that the child has a history of attention deficit hyperactivity disorder, ADHD. It could be that the child has depression, so the child is not even wanting to learn or interact. Prenatal alcohol exposure, seizure disorders in that child, neurofibromatosis, Fragile X syndrome, Turner syndrome, type 1 diabetes, okay? History of central nervous system infections like meningitis, like encephalitis, and central nervous system irradiation. So radiation, for whatever reason, the child was exposed to radiation very early in life. All these can cause learning disorders. So family history of learning disorders, poverty, prematurity in the child, attention deficit hyperactivity disorder, depression, prenatal alcohol exposure, seizure disorders, neurofibromatosis, Fragile X. In fact, all these topics, if you're able to master them, even though they are just risk factors, if you're able to master them under pediatrics, you are very good. Central nervous system infections like meningitis, like encephalitis. Okay, now I've mixed up this because we're saying that the issue of the learning goes in various areas of learning. So I want somebody connect the following learning disabilities with the right nomenclature. So this does not match to this. It's been mixed up. In the next slide, I'm going to give the right answers. So reading disability, is it a non-language-based learning disability, right hemisphere dysfunction? Is it dyscalculia? This is dysgraphia? Is it dyslexia? Disorders of written expression, what is it? Mathematical disorders, what is that? Non-verbal learning disorder, what is that? So if you see a child with, say, if I bring a question, 6-year-old child has disorder with mathematical calculation, what condition does that child have? Does that child have dyslexia, dysgraphia, dyscalculia, non-language based? So what I want you to do is that I've mixed up these ones and they don't match with those on the left. So just let me know. Reading disorder, reading disability, what is it? Disorders of written expression, what is that? Mathematical disorders, what is that? Non-verbal learning disorder, what is that? That's basically what this question is about. Dr. Naila, you wrote dyslexia, but I don't know what the dyslexia is about. Is it reading, disorder of written expression, mathematical, non-verbal? What is it? Okay.
Reading disability.
Reading. So I've seen a lot of answers, and I think someone just dropped a huge one, Dr. Tasman. Okay, so please, you have to know this. Reading disability is dyslexia. This can be a very powerful MCQ for you to review. Reading disability is dyslexia, okay? If a patient has disorders of written expression, that is dysgraphia. If the child has issues with doing mathematics or calculation, that is dyscalculia. And if there is non-verbal learning disorder, that is non-language-based learning disorder and right hemisphere dysfunction. Please, if you're having trouble with this, what I'll suggest is just take a screenshot or something. We'll be sending it to you anyway, but I know that some people at times will want to have specific things. So if you want, you can just take a screenshot so it can help you. So if you see someone with learning disability and you have A, dysgraphia, B, dyscalculia, C, dyslexia, D, whatever, you know exactly what goes with what. So reading disability is dyslexia. Disorders of written expression is dysgraphia. Mathematical disorders is dyscalculia. And non-verbal learning disorder is either non-language-based learning disorders or right hemisphere dysfunction. Doctors, please, can I proceed? I don't want to go faster than you want me to go. Can I proceed to the next slide?
Yes, doctor. Thank you. Very good.
Beautiful, beautiful, beautiful. Okay, so now let's talk about autism. So now remember what we are doing. We are basically looking at the first rationale of the objective, which says that we should be able to use the history and features of the condition to make a diagnosis. So that's what we are doing. So, and we learned that attention, learning, and school problems, there are about 12 conditions we should know. And we are picking about 4 of them to review in class today. So let's go to autism spectrum disorder. So a mother brought in her 6-year-old child for evaluation. Teachers are concerned about the child's behavior at school. You suspect autism spectrum disorder. Which features will you look out for? So poor eye contact, Dr. Tasman, eye contact, that's Dr. Ahmed. So Dr. Ahmed, you want to state, is it good eye contact, poor eye contact?
No, I meant to say no eye contact.
Okay, no eye contact. Dr. Lucci says rigidity. So features of autism, you know, at times we hear the topic over and over and over again, but have we solidified it? So let's go to up to date. Up to date says there's lack of delay or regression of spoken language. So there's delay of spoken language. Number 2, if the child even has spoken language, there is unusual intonations. There's echolalia. Echolalia is making unreasonable sounds and unreasonable words. Incorrect pronoun use. So like the person is a male, or the child is speaking to somebody who is a male and she's using she, or the patient is using you. Like, you know, it does not jive. And most of the time that is after if the child is 3 years and above. and non-speech-like vocalization, like, the child is grunting a lot, or the child is making squeaky sounds, okay? And limited to specific topics or interests. And so the child conversations are all limited to cars or food, or specific things. And they also have limited use of language or communication. So they use only single words, even though capable of speaking in sentences. And they have reduced or absent nonverbal communication like gestures, facial expression. It is reduced. And they have little or no response to other people's gestures or facial expression. So even when you are trying to give them nonverbal cues, they are not able to pick it up. And there's lack of response or slow to respond when they are called by their name, even though they don't have any hearing impairment and their hearing is normal. Okay? And then other features. So please, before I move on, are you okay for me to move on? These are the features of autism you want to know about. These are the features of autism that you want to know about. So some of them may also have little or no response to other people's gestures or facial expression, lack of response to their name being mentioned, even though they can hear properly. They also may have reduced or absent interest in or attempts to share interest with another person. Okay, they may have limited social interaction. So I've brought all this up. Just pause the video when you get the replay, or you can take a screenshot and then just use that to review features of autism. If you're able to learn about 5 features, that would be very good. So that if you are presented in a board exam situation, you'll be able to manage with it. Features of autism. You must be able to pick it up easily. Repetitive motor mannerism. So they may have, hand flapping like the child I showed you in the picture when we started, like this one. They may have they may have focus on just one toy. And even with that toy, they are just using repetitive movements all the time. They are resistant to change. So if I give you a question stem and I'm putting all these things, all these features in there, know very well that this is nothing but autism. And reenacting scenes from cartoons or movies. And they may have atypical play, they may have repetitive play, or lacking imaginative thoughts when it comes to play, or they may not be able to engage in no pretend play, and they may pay over attention to parts of object, like maybe the spinning of wheels instead of focusing on the whole car. This is something you want to watch out for. And these children also have lack or unusual reaction to sensory stimuli, like noise, texture, and smell. So these are the features of autism that I want you to pay attention to. Now, we also said that another condition that can lead to attention, learning, and school problems is fetal alcohol syndrome. Another important topic you need to review. So, can somebody read this question for us, please? And then try to answer it. And everyone can also type in your answers. I want a volunteer, please, a volunteer. Someone should just volunteer, and then we go.
You are evaluating 4 children in the pediatric clinic for learning disorders. You suspect fetal alcohol syndrome in one of them. Which of the following features below is not a feature of fetal alcohol syndrome? Microcephaly, macrocephaly, thin vermilion border, or short palpebral fissures?
Beautiful.
In my, it's macrocephaly.
Macrocephaly. So why not microcephaly? Why not short palpable fissures? Why not thin vermilion border? Because short palpable fissure, microcephaly, and thin vermilion borders are all features of fetal alcohol syndrome. The only one which is not a feature there is macrocephaly, big head. Macrocephaly, big head. So what is the teaching point here? What are the features of fetal alcohol syndrome? Features of fetal alcohol syndrome. Number 1, facial dysmorphism. When I say facial dysmorphism, the features on the face, please memorize these. Number 1, short palpebral fissures, a thin vermilion border, so up here, smooth philtrium, They may also have intrauterine or postnatal growth retardation. They may have microcephaly. So in that question stem, I put microcephaly, I put macrocephaly. Maybe next time I should even make it more difficult. Then they may also have structural brain anomalies and recurrent non-febrile seizures. I could have made it recurrent febrile seizures to confuse people, okay? And then behavioral problems like hyperactivity, impaired executive function skills, and social emotional problems. These are all features of fetal alcohol syndrome. So please know why we are doing all these, because we are learning about inattention, learning and school problems. And we are learning ADHD, learning disability, and now we are on fetal alcohol syndrome. So this is also a child with fetal alcohol syndrome. I have another picture which I'll show you. This is from Cleveland Clinic, like copyrighted in 2021. So they will have a small head, not a big head, a small head, small eyes, low nasal bridge, a smooth philtrum. So if you look at all of us, our philtrum, you can see a little wedge there, but a child with fetal alcohol syndrome, the philtrum is smooth, and they'll have a thin upper lip, a thin upper lip, a thin upper lip. This is also another picture. This one is from Up to Date of various children across various races who have fetal alcohol syndrome. So I just brought you those two pictures so that you'll be able to see how it looks like in a child who is dark-skinned, a child like a Caucasian, a child who is also Oriental or maybe First Nations. How will that child look like? Because at times you just have to look at a picture to make a sports diagnosis, right? So examples of fetal alcohol syndrome face phenotypes across 3 races: white American, Native American, African American. And they also look out for that flat philtrum, look for that palpable fissure, look at like the low nasal bridge as well. Now, after we've looked at the features based on history and physical exam, the next objective says, list and interpret critical investigations, including systematic hearing and vision screening, relevant laboratory tests like thyrotropin stimulating hormone, lead level, and psychological cognitive testing of behavioral checklists like ADHD screening tools. So it's still with that same thing. So in other words, how are you going to diagnose fetal alcohol syndrome? If you have a case of fetal alcohol syndrome and you see any lab results that we are going to use this lab results to diagnose fetal alcohol syndrome, please run away from that option. It is a wrong option. It's wrong. You make a diagnosis of fetal alcohol syndrome with 2 things. Number 1, when you are told in your question stem that the mother was exposed to alcohol, and then any of the features of fetal alcohol syndrome that we talked about. So number 1, there must be a history of exposure to alcohol by the mother when the mother was pregnant.
Okay.
And then number 2, there must be a feature like what we talked about. So it's either the vermilion border, palpable fissure, microcephaly, structural brain anomaly, any of those plus a history of a mother who was exposed to alcohol. Boom. The answer is fetal alcohol syndrome. We don't use any lab results to make that diagnosis. Please, doctors, let's make it clear here. How do we diagnose a patient with fetal alcohol syndrome? 2 things. 2 things. Number 1, history of mother taking alcohol. Number 2, any of the physical features which we've learned about. Now let's move to ADHD. ADHD as well, you don't need any laboratory investigation. So fetal alcohol syndrome is based on history and physical exam features. ADHD as well does not require blood. So if you see, how am I going to make a diagnosis? Do blood lead levels, do TSH levels, do neuroimaging, do electroencephalography. It is wrong. The only time you use those is when, it looks like this is more than ADHD and therefore I need to do further evaluation. But in reality, board exam standard, medical school level exam for QE1 You don't need any specific investigation to help you to confirm ADHD. ADHD is a clinical diagnosis. Number two, if you're also told that, oh, the child responded after being given Concerta or any stimulant, that does not necessarily confirm ADHD. So the point two I made there is the response to stimulant medication cannot be used to confirm or to refute the diagnosis. How are you going to make a diagnosis of ADHD? The child should have inattention, hyperactivity, and impulsivity in two settings, either at home and school, either at home and after school program, or either in school and an after school program. There's no laboratory investigation for that. Doctors, please, can I proceed? I want to be equivocally clear. I don't want to be confusing in my communication about this. Beautiful. Okay. How are you going to learn specific learning disorders? Or how are you going to diagnose it? The diagnosis of specific learning disorders is made by history. If you have the option of, oh, we did psychometric testing to make the diagnosis, the psychometric testing comes to confirm. It does not help you to make the diagnosis of the birth. If you want to make the diagnosis primarily by history, this child is 5 years, but is performing at the level of a 2-year-old child. Instead of this child performing at grade 7 level because she's this particular age, this child is performing at grade 2 level. That's how to make the diagnosis. How do you confirm that diagnosis? Then you use psychometric assessments. And the psychometric assessments we use, the psychometric assessment, and then after that, you assess the child with standardized psychometric assessments, like they have learning skills, and then the child's educational history. So you can take a history from parents, from teachers who have been with the child, and then description of classroom observations, those 3 things. But in reality, you use history to make a diagnosis. You use psychometric measures to confirm your diagnosis. Hello, doctors, are we all on the same page? Are we all on the same page? I know, this is not a typical hyperkalemia, hyponatremia, myocardial infarction, but it's a very, 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 very important MCC objective, which we must review. Beautiful, beautiful. Okay. And as I said, there's a last part to this class, but I wanted to let you know what is happening. Many of you on the call are IMGs. You realize here that the average score among Canadian medical graduates, look at it, 262, 252, 257, 255, 257. I'm telling you for a fact, everybody who is getting above 250, at least, will get an interview. At least. People have even gotten less than 240 and have still gotten interviews. People who are getting, so you realize that the mean score among Canadian medical graduates is really high. But if you come to international medical graduates, if you look here, the mean score, meanwhile, the pass mark is 226. And the mean score among international medical graduates is 228, 233. And after that, it came to 227, 228, 228. So just 2 points above the pass mark. That is where my concern is. That is where my concern is. And so when I hear people like Dr. Bassett making the transition and saying that, Dr. Bonnie, I did your sprint course, and because of that, I wanted to get into the full course, I go like, yes, you've made the right decision. And you realize that even IMGs who fail the exam, now their mean score even drops to 223, 223, 218, and all of them is a fail because the pass mark is 226. So I just wanted to bring this so that we really know the reality. Out of every 2 IMGs you meet, 1 has failed the exam before. Meanwhile, the pass rate among CMGs is 96.4, 82.3 in July 2021. September 2021 was 89.1. October 2021 was 93.5. January 2022 was 92.5. We've not gotten the the breakdown for the rest of the sessions in 2022. If I get it, I will let you have it. Now, let's go back to what we are studying. How are you going to manage a child with ADHD? Who can help us? What's your first line treatment option? Family therapy. Okay. Cognitive behavioral therapy, psychoeducation and support. Now, let me bring this up. Psychoeducation is your non-pharmacologic approach. And after that, I'm going to show you something in relation to the number six, the number 6. And you can also have behavioral management, parental training, classroom management, social skills training. So these are the non-pharmacologic options. And the pharmacologic options, our first line is stimulants, like methylphenidate, amphetamines. And then the second line is a non-stimulant, something like atomoxetine and guaifenesin. So atomoxetine is a non-stimulant drug which is used to manage patients with ADHD. And then the third line, you can then go for medications like clonidine, bupropion, imipramine. But remember that the non-pharmacologic options for the management of ADHD is psychoeducation, behavioral management like parent training, classroom management, social skills training, and pharmacologic management like stimulants. Atomoxetine is a non-stimulant. Clonidine, bupropion, imipramine. Now, at times, that child with ADHD we learned may have anxiety, may have some other psychiatric conditions. So depending on if the child has ADHD plus anxiety, then you can give them some anxiolytics or antidepressants. And if they have ADHD with some psychotic features, you can also give them antipsychotics. But remember that I told you that there's something very important about the number 6. If in your exam and you suspect that this child has ADHD and the child is, say, 7 years old, your approach is a bit different from a child who is 4 years old. Because remember that we said ADHD is diagnosed in children who are equal to or more than 4 years old. But number 6 is a very important number. What do I mean by that? If your question stem says that the child is less than 6 years old, then you can use psychosocial intervention alone as a first line. But if the question stem says that the child is more than 6 years old, then don't use psychosocial intervention alone. Use psychosocial plus a medication. And can somebody remind me, what are some of the medications we use for the management of ADHD? What are some of the stimulants we use? What are some of the non-stimulants? And what's the third line? Can somebody help me? What are some of the medications we use?
Methylphenidate, amphetamine, first line. Yeah, second line is atomoxetine and guanfacine.
And then third line?
Third line, clonidine, imipramine, and bupropion.
Beautiful, beautiful.
Yeah.
And will you start medication if the child is 5 years right away?
No. It's psychosocial intervention. Yeah, less than 6 psychosocial intervention, more than 6, they will be psychosocial plus medication. Yeah.
Beautiful. That's it. That's all you need to know. Okay. Now, what is one unique thing about methylphenidate or the stimulants? When you prescribe stimulants, what is one thing you tell the mother to observe in the child? Can somebody help me? If stimulants are prescribed, what is one thing you will encourage the mother to monitor and to observe?
The weight, Chief. The weight.
The weight.
Yeah.
And in relation to the weight, what is it about the weight? The appetite, right? The appetite. Remember, this is a board exam. Board exam. Specific things are specific for board exam. The weight, appetite, stimulants, you monitor weight and appetite. Non-stimulants, you don't really waste your time with that. What about fetal alcohol disorders? Fetal alcohol disorders has no cure. Basically, you want to put them through community resources and services to improve outcomes. That's fetal alcohol disorders. And then for specific learning disorders, you want to provide quality instruction for specific learning disability. And you also want to get them school support, like modifying the curriculum, providing accommodations like scribe for writing, extra time for their test, photocopied notes, so that they can, focus and get things done. Individualized educational plan and specialized educational placement that can provide education remediation. Because this child will definitely have, this child will definitely be a little backward as compared to the rest of the class. So you want to get as much help as possible for this child. So I want 4 doctors to volunteer. If you can raise your hand virtually, then one will summarize ADHD, features, assessment, management. Another one will summarize specific learning disorders, features, assessment, management. Another one will take fetal alcohol syndrome, features, assessment, management. And another one will take autism spectrum disorder. Please, who will volunteer and take the first one for me?
For ADHD, it's going to be inattention, activity, impulsive. That's the features, the impulsivity. And what else I should cover?
Yeah, cover the assessment.
Okay, so for the assessment, we need to do assessment in 2 different settings, like school, home, school, after school. And that will be like a psychoeducational assessment. We can start screening age 4 years old. Treatment though, like the medical, like pharmacological treatment, that above age 6. For overall, like regardless of the age, we have always start with the non-pharmacological treatment, which is psychoeducational support, academic support and accommodation, family support and social training and all of that. That's regardless any age, but for age above 6 only, we can do pharmaco, which is a methylphenidate, amphetamine, the stimulant, first line. Second line, non-stimulant, which is etoximab, something like that. Third line will be clonidine or Wellbutrin.
Atomoxetine, atomoxetine,
Beautiful. Beautiful. Okay, so who takes specific learning disorders?
Yeah, in specific learning disorders, there is dyslexia, there's one, dysgraphia, dyscalculia. Dyscalculia is a problem with the calculations, and dyslexia is a problem, dysgraphia is a problem with the writing, dyslexia is a problem with the reading, and dyscalculia is a problem with that is the calculations. And non-verbal, non-language based learning disorder, that is called non-verbal learning disorder. Yeah. And in the learning disorder,
how do you make the diagnosis of specific learning disorders?
We will make it learning disorder. Yeah, we will diagnose it by history.
Beautiful.
And psychometric measures. Yeah.
How do you
how to confirm? Yeah.
Yes, that's psychometric. Beautiful. And how do you manage them?
Learning disorder. We will manage them with some psychomotor training or something like. I can't recall that one.
So it's also making accommodations for them, right? Accommodation. Yeah, getting them some support and everything. Okay, who will take fetal alcohol syndrome for me? Fetal alcohol syndrome.
Well, Chief, yeah.
Okay.
Fetal alcohol syndrome. In fetal alcohol syndrome, there's a history of the mother, haven't been maybe have always been used to the intake of alcohol, and the clinical features the children they tend to manifest. One is the facial dysmorphism. Then you could also have short palpebral features, smooth philtrum, then grow to the addiction. Then at times they could come up with microcephaly, then brain abnormalities, and also they could also have recurrent febrile seizures, social emotional problems, and also they could also have thin lip. And also it's also common with white American children. It runs across the races, and for the African American also. Then also for the diagnosis, then we said you don't do any, there's no investigation, if I could understand it. Then, but it's clinical majorly, where you must have an history of the mother having said to have taken an alcohol, then with any of the features that was listed among the features. Then also, think
in relation to the head size, is it big or small?
Yeah, the relation to the head size is small.
Beautiful.
Yes, it's small. They have small head microcephaly.
Beautiful.
Yes.
And how will you manage a child with fetal alcohol syndrome?
Yes, so that one.
It's similar to the learning disabilities. So because this learning, so they must get, an extra tutor, they must be given extra time to work, they must be given like photocopy notes, those things.
Okay, do we have to, is it also the same, the management, is it also the same thing as the management of the attention deficits, the AD, managing the ADHD?
Well, with the ADHD, we have stimulants, non-stimulants, like
yes, non-pharmacological approach and the pharmacological approach.
But most
where
of the
we have
alcohol syndrome, it's non-pharmacological unless they have a medical or psychiatric condition which warrants a medication,
Okay, Chief, please, I want to ask, I want to clarify this. In what when will you do an investigation? Is it that if there is any neurological problem?
Yeah, for example, we have somebody with fetal alcohol syndrome, and that we said, what kind of seizures do they have? We said non-febrile seizures, right? Recurrent non-febrile seizures. So if you have somebody with fetal alcohol syndrome and they start having non-febrile seizures, definitely you want to do all the investigations you need to do for a child with seizures, like a head CT, an EEG. You want to check electrolytes to make sure that everything is good. So but if it's fetal alcohol syndrome, you confirm it with history and then physical features, then just leave it like that.
Thank you very much.
You're welcome.
Thank you, sir.
Okay. So who would take autism spectrum disorder for us, please? Autism. I need somebody to take it for us. So someone with repetitive behavior, like what Dr. Anum said, poor social interaction, cannot keep eye contact, fixated on specific things, has echolalia, uses some specific words, is always fixated on specific parts of objects, basically that. How do we make the diagnosis? It's also clinical, based on history and seeing the features. So remember, look, the reason why we are doing all this is because the QE1 is not a highfalutin exam, but it's very broad. And if you are using the objectives, that is when you can conquer everything you need to conquer. Keep it very simple in your preparation. Forget about the highfalutin ideas. When you go to group studies and, and the truth is, among IMGs, we have candidates who are time specialists in their country and all those things. Please, it is necessary that you remember that, yes, you are a specialist, but then you are taking an exam at the level of a medical student. So don't take, don't take your discussions too high, or else you spend time, because we've used 1 hour to talk about 4 main topics: features, clinical evaluation, and management. Don't take your discussions to very high levels, and then you are spending almost 3 hours talking about fetal alcohol syndrome. Why? Because you were a pediatrician at home. That's fine, but that is not what is needed here. Doctors, please, are we all on the same page? Because I see this over and over and over and over and over and over again. And for me, it makes me worried. it makes me very worried. Like, you know, people go to group studies and then now the group study becomes like a very high, forget about that. The exam is very straightforward. Clinical diagnosis, assessment, management, investigations, complications, boom, you go. So the approach you use really, really matters. And that is why I am hitting on it. You can't use any haphazard approach to this exam. That is why I say that I don't like it when candidates come, Dr. Boni, I have 1 week to my exam, help me. I will not be able to do anything. But if you want, you know, help with the way, like a systematic way, okay, Dr. Boni, I have 3 months to go, guide me. We will do that. I have 4 months to go, guide me. 5 months, 6, sure. But or even 2 months, but to come saying, I have not studied, I have 2 weeks to go. I will not want to get myself in that situation.